Please welcome with me Dr. Rayid Abdulqawi, who will be talking about OCS stewardship and clinical remission. How much further can we go? Dr. Rayid is a consultant transplant pulmonologist, King Faisal Specialist Hospital and Research Center, adjunct associate professor, College of Medicine at Faisal University. Please welcome Dr. Rayid.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. So it's very great to have the third Abu Umar in a row. So Dr. Muhammad Zaytoun Abu Umar, Dr. Riyad Abu Umar, and me Abu Umar as well. So my talk is going to be really a summary of what we've heard so far, because I think after hearing what Dr. Zaytouni and Dr. Al-Haybi presented, I think it leaves no additional comments. But I always, when I do presentations, I always start with history. And in the early of the 20th century, asthma was recognized as like a spasm of the airway muscles. And one of the treatments offered to patients was asthma cigarettes. So it's a kind of inhaled delivery device to the lungs. So they were inhaling some kind of leaves and some anticholinergic medications, and that was the start of the asthma treatment. And then we moved to a new era. So I don't know whether any of you recognize these three guys. No? Okay. So these are the Nobel Prize winners in 1950 for the discovery relating to the hormones of the adrenal cortex, their structure, and biological effects. So the way that we practice medicine, especially in autoimmune diseases, inflammatory diseases, asthma, is mainly shaped by these three scientists and clinicians, two of them, Dr. Kandel and Dr. Henge from the Mayo Clinic. So they discovered the cortisone. And now, before it was BC, before cortisone, now it's cortisone era. And then you can start to see publications and news spreading all over the world. So as this one from the New York Times in 1951, saying cortisone, these miracle hormones produce amazing benefits and provide clues to basic knowledge of the body. And cortisone being produced in the lab is significant in its ability to turn disease off and on. So that was history. And then there started some observational publications relating to cortisone and asthma. So as you can see, this publication from the 1958 describing the treatment of chronic asthma with prednisolone, significance of eosinophils in the sputum. So this is over 70 years that we've been talking about eosinophils and cortisone. And you can see that they're describing a group of young patients we thought they have to have bronchitis. And they said that these had eosinophilic sputum and responded dramatically to prednisolone with relief of bronchospasm and usually cessation of recurrent bronchial infections. However, subsequent to that, there was a development of the inhalers, and especially the inhaled corticosteroid was in the early 1970s. And, but soon after that, the scientific community started to recognize the side effects of corticosteroids, as you can see in this publication describing the effects of cortisone on the stomach. So the peptic ulcer disease related to corticosteroids, and that was in 1958. And that was part of our treatment for asthma. So Gina in 1995, in step 4, had given the option of treating severe asthma patient with long-term oral corticosteroids. However, corticosteroids are double-edged sword. So they have helped and saved the lives of many patients, not just in asthma, but in autoimmune rheumatic diseases. But they've come with cost. So we're all aware of their harmful effects across all organs and systems of the body. And if we look at the prescription of oral corticosteroid for asthma, so it's not just here in Saudi Arabia, so globally, and there are many reports published about that the prescription of the steroids for asthma is very common. So If you look at this prescription data from the Netherlands of over 180,000 patients with asthma for the period between March 2017 and March 2018. And you can see that there are almost 7 or 8% of asthma patients were classified as frequent steroid users. Either they had been on maintenance corticosteroids or they received at least 2 courses of corticosteroids. And what's astonishing is, as we've heard from Dr. Rayid Al-Haybi, that almost half of those with frequent oral corticosteroid use were receiving only low or medium dose inhaled corticosteroids, which means that their asthma was not properly addressed and managed. And if you look at a patient who been on oral corticosteroids, half of them, for those who received at least 2 courses of oral corticosteroids, had no specialist review, and this is in the Netherlands. And a third of them, of those who received the maintenance oral corticosteroids, again, had no specialist review. So this indicates that oral corticosteroid overuse is often underdiagnosed because those patients were still taking low-dose inhaled corticosteroid and inadequately addressed because they were not referred to specialists for review. And the long-term consequences of oral corticosteroids, both for maintenance and multiple short burst prescriptions, is really significant. And something that we never think about when we prescribe corticosteroid is that the cumulative lifetime dose, because if you go and have a CT scan and in another year do another CT scan, so that's all cumulative dose of radiation. So the corticosteroid prescription that you had this time, it adds to the previous prescriptions, to the previous doses that you received. And what's astonishing is that the lifetime cumulative dose of as low as 500 milligram is associated with serious adverse consequences. So it's very clear that even with low doses of corticosteroids, there are some healthcare consequences and increased costs associated with that. And also the increased mortality for those with a chronic corticosteroid use. So the ID community have moved to antibiotic stewardship. So when you prescribe antibiotic, you choose the right drug, the right dose, the right duration, and you try to de-escalate. And if you look at the dictionary of the definition of stewardship, it's not about eliminating the use of something. It's not about erasing it. It's about controlling it, and it's about organizing it. And that's why with the widespread use of the oral corticosteroid, as in every hospital, they have the infection control, infection prevention, antibiotic stewardship, but we hardly hear about corticosteroid stewardship. And to achieve corticosteroid stewardship, you have to have a multidisciplinary approach, multidimensional asthma assessment. So as we've heard before, that you have to confirm the diagnosis, you have to confirm that it's severe, is adequately addressed, and whether the patient adherent to the treatment, and you identified all the triggers, you identified all the comorbidities, you appropriately phenotyped patients, and you controlled all the triggers, the factors associated with exposures. And then you reach out to biologics if needed. So we're trying to avoid the use of corticosteroids when possible. So just briefly that because, as I said, that we started with the era of inhaling cigarettes as a treatment for asthma. And then there was discovery in the 1950s of the corticosteroid, and there was a new era of the corticosteroid. So it was BC before cortisone. Now it's BB, so before the biologics. So now we are in an era of biologics, and we all have heard and known about the benefit of these biologics. So for example, the mepolizumab, 50% reduction in the corticosteroid for those who are on maintenance, associated also with a third relative reduction in exacerbation. The same with the pembrolizumab, so 75% reduction. compared with 25% reduction of oral corticosteroid in the placebo, and also in association with halving the risk of exacerbations, also in the dupilumab. So the message is that biologics have enabled us these days to reduce or eliminate the oral corticosteroid and improving outcomes. So before we had steroids, so we're talking about clinical control, and we're looking at day symptoms, nighttime symptoms, the use of the reliever. But now we have, as Dr. Rayid Abdulqawi has mentioned, that we have the biologics, which has enabled us to talk about clinical remission with various definitions. And for example, this one, the consensus from the American College of Allergy, Asthma, and Immunology, describe those with being in remission on treatment as those with no exacerbations, no missed work, stable or optimized lung function, and good asthma control, and symptoms requiring one-time reliever therapy no more than once a month. And as Dr. Rayid Abdulqawi has mentioned, that we have people who are using a canister a month, and a canister, I think, that it delivers 200 doses of Ventolin. So if you imagine if you have once a month, that means that maybe at least you're using Ventolin 3 times or 4 times a day. Clinical remission is not just a theory, it's already in our daily life, and I've obtained this from Dr. Rayid Abdulqawi from the Severe Asthma Registry, the international one, and you can see with various definitions of asthma remission that we're able to achieve that with the biologics. And now we are started talking about clinical remission as a target and goal for severe asthma treatment. There are many barriers for oral corticosteroid reduction in severe asthma, and they could be related to patients, could be related to clinicians, and also to the system. So many patients are familiar with the oral corticosteroids. The clinicians are afraid of the adrenal insufficiency, or the systems that, as Dr. Rayid Abdulqawi again mentioned, that there is limited access to specialist asthma clinics. Just quickly referring to this study that has enabled the oral corticosteroid reduction, even in those with chronic maintenance oral corticosteroid, and it was successful that in the majority of those patients who were prescribed benralizumab, that they managed to eliminate or reduce the oral corticosteroid dose despite being on long-term corticosteroid. Kind of summarized everything from the previous talk, that to achieve stewardship, we need to be educating our patients. We need to enable access to the specialist asthma clinics. We need to support the clinicians and the systems to enable the strategies of oral corticosteroid sparing. Nowadays, you won't be able to get antibiotics from pharmacy, but you'll be able to get multiple bags of oral corticosteroids from pharmacy. And even when I was in the UK, if you go and buy paracetamol, because people were using it for suicidal attempts and these things, you are not allowed to have more than 2 or 3 packs of paracetamol. But the patient can get 100 packs of oral corticosteroid without any monitoring or restrictions. Now, if you remember that in 1995, GINA recognized oral corticosteroid as a treatment for severe asthma. Now GINA 23 has oral corticosteroid just at the bottom right corner of the treatment, so it's even very hard to see it. So my take-home message is that we have to remind ourselves that the oral corticosteroid are still associated with costly adverse effects and complications, and that we are not talking about steroid elimination, because steroid is still saving lives, especially in acute exacerbations, but we're talking about stewardship, minimizing unnecessary exposures, and we need specialist asthma services to enable the optimization and using the corticosteroid sparing interventions, and we have to work to achieve asthma remission, and this is our goal. And thank you very much for listening.